Good morning, everyone, and welcome to the University Hospitals Health Services Research Distinguished Speaker Series. My name is Dr. Dan Simon. I'm the Chief Academic Officer and Chief Scientific Officer for University Hospitals. And it's really an honor and a privilege today for our Health Services Research Center to be able to welcome Professor and Dr. Mike English from Oxford. He is a UK trained pediatrician who has worked in Kenya for over 25 years as part of a very important effort related to building health system collaboratives in a variety of settings in collaboration with the Ministry of Health and the University of Nairobi. He established the Clinical Information Network there in 2013 and has developed an incredible platform over the subsequent decade as an example of a low-cost learning health system that now spans 24 Kenyan hospitals. This network implements and informs national evidence-based clinical guidelines, supports large-scale improvement interventions, enables the conduct of large pragmatic clinical trials, and some of the largest hospital-based observational studies in Africa. He is now extending his work to Vietnam, Burundi, India, the UK, and Ghana with a strong focus on capacity building of these health systems. Before we begin, Mike, I just wanted to say to everyone, we are recording this webinar. Please mute your microphones throughout the presentation. If you have any problems, please chat with Nicole Bollinger or Abigail Zona. And finally, for those who are invited to the meet and greet session after the presentation, please remain on the Zoom after the completion of the Q&A. So Professor and Dr. English, it's all yours.
Thank you very much. Let me just share my screen. So I hope that's visible to everybody. So I'm going to run through some stuff pretty quickly. And hopefully, if you don't catch it, you can get some clarification from me at the end. So as I've been introduced, I'm now currently in Oxford. And what I'm going to talk about is what we've done over the past 10, 11 years, as was mentioned with what we call the Clinical Information Network. Some of you will know about the principles of a learning health system, although there's a few varieties of those things. But I'm going to give you, in one sense, the history and where we've got to. So this is the plan for the presentation. Sam said it would be useful just to get a quick idea of how I ended up where I am. The bottom line is it was never planned. As was mentioned, I'm a UK trained pediatrician. I took a period out of service for a few years, ended up in Kenya working in a district hospital, turned the work I was doing there into a doctorate. Had to come back to the UK to complete what we call specialty training. But then during that period, wrote a Wellcome Trust Fellowship grant to go back out to Kenya. And in that sense, I have been completely research funded through fellowships for the last 20 years or more. So in terms of long-term strategic planning, it was more about getting every few years funded rather than having a goal in mind. Now back in Oxford, running a multidisciplinary group, still strongly related with the Kenyan team, but working in other settings, as was outlined. So I think you'll know this, but just in case, just a quick reminder of where Kenya stands. So you can see this is the total spending on health, how far behind most of Africa is. Kenya is actually not by no means the worst off African country in terms of spending on health, but it's under $100 per head per year. It's a different demographic, which makes my specialty of pediatrics a bit more interesting in this part of the world. And it's got a huge problem with lack of health professionals, although we can discuss that later. So this is just the context within the hospitals or the country, and then the hospitals I worked in, because all the hospitals we work with are public sector hospitals. This is another quick insight into their level of sophistication. So certainly at the beginning of the network, what we found is even in large hospitals, and I'll show you a little bit about how many patients they have later, they could typically manage nasogastric tube feeding. Laboratory service is extremely weak. so they may or may not be able to do a simple blood glucose. Blood chemistry was almost entirely lacking. They certainly couldn't do any microbiology, which makes true diagnosis somewhat challenging, as you can imagine. And simple technologies like pulse oximetry were beginning to come in, but really very patchy. CPAP, particularly in the newborn units, was largely not present at the beginning. And simple other supportive technologies such as electronic syringe drivers or fluid monitoring pumps were essentially lacking. So we were working in a very low resource setting, trying to develop a learning health system. And just obviously, in these settings, there were no functioning electronic medical records, and that actually remains the case for inpatient care in the public sector in Kenya. You'll understand the principles of learning health systems. The principles that we have been working on are those originally espoused by what was then the Institute of Medicine some 15, 17 years ago. And the whole point was to try and use routine data. So we use clinical data rather than research data. If we can get reasonable high quality data, then we want to try and use it to improve care, and that includes implementing better practices. But if we can then get high quality routine data from multiple settings, that enables us to do observational and interventional research at a scale that is often not done in these settings because of the difficulties of having good data. And obviously we could do none of this without creating a really quite extensive network of stakeholders and doing much of the hidden work of actually building those relationships over a period of years. We started our journey in sort of database and a proxy to electronic health record development by conducting one of the first randomized controlled trials of hospitals to understand how you could improve care almost 2 decades ago. And part of this involved using structured paper medical records. And obviously, if you have a structured paper medical record, it makes data abstraction much easier, something I'll come on to. But if we wanted to improve care, we also need to define what good is. And that was actually something that was missing in most countries at the time we started, or a little bit before we started. So I was involved in lots of work initially in terms of actually creating national guidelines and using evidence synthesis to do that. And part of this work involved informing the first iteration of the WHO's Pocket of Hospital Care for Children, which was first published in 2006. But we were actually the first team, in fact, before WHO, we were the first team in Africa to be using the GRADE process for assessing the quality of evidence and running national guideline panels with multi-professional stakeholder groups. And we started this process in 2005, so actually well before the network. And what we did was select priority topics, conduct evidence syntheses in Kenya with Kenyans, take those into guideline development panels and create the job aids, which are the guideline booklets, de novo, because these didn't exist. And so part of our work was then essentially trying to embed these in routine clinical practice across the country. The first round of this it proved to be extremely helpful and successful. And essentially we've done multiple rounds since then. And then in the 5th round, not shown here, it was actually completely led by the national government. And so we've been able to step away from this process. But throughout, and this is part of building our stakeholder network, we've involved well over 100 people in the process of systematic review, and then had many hundreds of people involved in guideline development work. And the value of this is that people on the ground feel that they own the guidelines. And so they have decided what comprises good quality care, at least when it comes to the technical components of care. And interestingly, during this process, we started to get observers from other East African countries, and many of the products that we produced have now been disseminated across East Africa. Guidelines are one thing, as you know, you can give people the material that they should follow, and then you've got to enable them to follow it. And so part of the other aspect of what we did was essentially develop something that was much more appropriate to the East African context. It was a bit like what you would think of as a PALS course, but got rid of some of the high technology stuff, which was clearly inappropriate for the settings we were working in, but also I mentioned earlier the huge lack of health workers. So in one sense, if you resuscitate a baby or you're helping to resuscitate a severely ill child, there is no cavalry that you can call. You can't press a button. In fact, there are still no alarms. If you've got an emergency incident in a hospital, you can't press a button and the experts will arrive 20 minutes later. You're actually having to manage the patient from the initial 20, 30 minutes and then through to the first 24 to 48 hours. And when I talk about who is managing it, this is actually your first year interns who are doing pretty much all of this work, because there are one pediatrician in a hospital with several thousand admissions a year, combining their pediatric and neonatal admissions. And there are no residents who are partway through training in these hospitals. So essentially you've got your first year interns and one, sometimes two pediatricians. And what that means is that these extremely young doctors are actually managing severely ill patients for the first 24 to 48 hours. And so a lot of our work was emphasized trying to give them the right initial tools to do the best job possible for at least the commonest conditions. And if you remember back to any of your own training, you'll probably remember that you might do 6 or 8 weeks pediatrics in your medical training. So you're by no means expert by the time you are graduated. And as I say, the evidence-based work on the syntheses then fed into the design of these protocols, so they have been updated, and as I say, also now moved into other countries. A byproduct of this process means that we had to create a competent set of trainers, and we focused very much on the competence of the trainers, not their profession or their level of distinction, if you like. And it also meant that we were able to embed these guidelines and the training in the National University and now in many other medical schools, so that many of these topics have become examinable subjects for the medical students who then go on to become the medical officer interns that work in these hospitals. So if you like, that was precursor work. On the basis of a lot of that, we felt able to launch what we call the Clinical Information Network. And what I'm showing here on should be the right side of your screen is the overall architecture. So we were based in Kemry Wellcome, which you can see on your screen, and we were working with the Ministry of Health. We were working with county public hospitals, and we were also working with the professional community. And the reason for that, just as it is in the US, bodies like the American Association of Pediatrics are actually very influential when it comes to clinical practice. And so we wanted to engage that community, again, to reinforce the idea that what we're trying to promote is best practice for the setting. And the setting is very low resource and very unskilled providers. So you'll see on your left an example of a structured admission record form, so that the medical officer intern admitting a patient to a newborn unit in this case. This is both a job aid, but also therefore a much easier format from which to abstract data. And so what our system relied on is having just one single clerk at each hospital. There were no research staff present in the hospital, just one single clerk at the hospital who, when a patient was discharged, was able to abstract quite extensive volumes of information from these structured medical records. And we've had other structured medical record tools put as well. We didn't supply any of these materials. So part of the deal with the hospitals and the network is that they have to provide the structured medical records, which has been challenging for some of these hospitals. Sometimes even have trouble getting enough paper to keep their operations going. And part of our network idea was that the top left picture shows a set of pediatricians out in these hospitals who are therefore become the people that we are directly partnering with in each hospital. And for this network to work, they are the local supervisors of both what the medical officer interns are doing in terms of generating good routine data, but then also monitoring their practice and working on improvement projects. So we started off with 8 hospitals just over 10 years ago. As mentioned, we're now up to 24 hospitals. I'm a pediatrician, so not surprisingly, we started off on pediatric wards. We moved into neonatal wards, a key area of interest. And then obviously with COVID, there was a huge need to understand what was going on in severe acute respiratory infection in adults. And the government of Kenya had absolutely no data at an individual patient level from its public hospitals on this. And so we pivoted some of our data collection activities to actually provide that data from 12 hospitals during the COVID period and for a couple of years afterwards, which was essentially able to track how much severe acute respiratory infection as a syndrome was happening. And again, the resource limitations meant we knew how many cases met syndromic criteria, but even in these public hospitals with large numbers of admissions, it was actually not possible even to do a rapid test for COVID for most of them. So then what do we do with the data? So the first thing, as I say, is we had to create our data system, and we were aiming to do this so using products that required no licensing. So we use Linux as our platform. We use RedCap, which I'm sure you're familiar with, as a non-proprietary tool, and all of our other work is done with R or increasingly now with Python. So the aim was that these government hospitals did not have to pay any license fees for any software. So that was the stage 1. And then when we started getting data, and you'll see this goes back to March 2014, when we started getting data, we were able to develop tools which allowed us to feed back to hospitals exactly what was going on. And so this example is one hospital in which we were able to feed back to hospitals that although the national guideline for severe malaria treatment had changed to artesunate, they were not yet using artesunate, which confers a survival advantage on severe childhood malaria. We were able to use these data, and feedback directly to pediatricians and hospitals. And you can see in this case, there was a very rapid switch from the old treatment, quinine, to the new treatment, artesunate. So one example of a quick win in terms of quality improvement. Another example of a quality improvement strategy, and this now goes across multiple hospitals. As part of our network, what we did was we met pediatricians every 6 months. We asked them what was their target for making sure that all admitted patients had their HIV status ascertained. And they said their target was 80%. And you can see at the beginning of this process that essentially that wasn't happening at all. And it took about 18 months for them to hit their target, but we were doing nothing for the hospitals other than providing them with data, engaging them in this peer-to-peer network, and meeting them 6 monthly. And any activity at the hospital level was being done by the pediatricians with their staff. Other examples of how we've then been able to use these data are to understand some of the system challenges. And in this case, we've looked at childhood TB, one of my Kenyan colleagues. And on the left axis, because we're looking at large numbers of patients, this was done some years ago. There were 40,000 admission episodes, and almost half of them qualified on the basis of clinical history and clinical symptoms as potential TB cases. And that's partly because pneumonia or respiratory illness is a major cause of admission still. And you can see on this cascade that essentially the key issue here is that people were not investigating any of these children. So although they had met some criteria for possible TB, they were rarely investigated for TB. And this is in a period where huge amounts of funding were going into paying for GeneXpert. All of these hospitals had GeneXpert machines, and their use by the pediatric population with severe respiratory disease was essentially negligible. And this is despite pneumonia in our setting having a mortality on inpatient wards of about 8 to 9% average. So these are very sick kids who are not getting investigated. So this is a major diagnostic, if you like, quality issue. Technologies. Everybody thinks technologies is going to change the world, and I'm sure they will one day, and maybe not in ways we want. But this is an example of how a very cheap, very old technology has still taken 5 years to reach modest levels of adoption. This is just a single pulse oximetry measurement on admission of children to pediatric wards, as I say, with a mortality on the ward of an average of 7 to 8%. So very sick children in general, and it's still proving difficult to get a single pulse oximetry measurement done just on admission to help with classifying disease severity. We've worked on improving patient monitoring, and it's resistant in many ways for reasons I might explain later. But one of the things we did was use a human-centered design approach to work directly, in this case with neonatal nurses, to redesign their paper charts, which they still use, and consolidate 4 charts into 1 chart. And over a period, again, of about 24 months, there was slow improvement in the degree to which these sick newborns actually got some form of effective monitoring. So by no means job completely done, but moving in the right direction. Sticking to neonatal wards, another long-term improvement project has been about reducing neonatal hypothermia, which, if you're not neonatologists, just to remind you that neonatal hypothermia is associated with a quite considerably elevated risk of death. So the hypothesis being, if we can reduce neonatal hypothermia, we'll reduce mortality. And again, just to point out, what this is now we're able to do this on large numbers of patients. In this case, nearly 50,000 patients involved in this 3.5 year study, during which, again, we were giving feedback. So any changes observed are down to what was happening locally. I'll switch from quality improvement now to some observational research. And again, this is the advantage of being able to do things at reasonable scale. So in a relatively early work some years ago, we looked at blood transfusion, which is often required for treating severe malarial anemia when children may arrive with respiratory distress and a hemoglobin less than 5 grams per deciliter, which is really pretty low. And what we were able to show is that where the blood transfusion system was not working well, and so that there was a delay in the transfusion being executed after a transfusion order. So if the delay was 24 hours or longer, you got an 80% increase in the odds of death. In other words, this was not something the hospital provider could do something about. It was an indication, really, if you like, of the system competence to respond to the problem of severe childhood anemia. We've explored the association with measures of good practice, in this case, ability to correctly prescribe intravenous fluids for children, and young medical officer interns who do make a correct prescription, their patients with severe dehydration have a 30% reduced odds of death. And again, we were able to detect these effect sizes because we were working with up to about 10,000 cases. And now, focusing on severe pneumonia, what we were able to use is 14,000 cases of severe childhood pneumonia in Kenya to provide data to the National Ministry of Health to suggest that the WHO revisions to their guidelines were probably not inappropriate for Kenya. And so Kenya, on the basis of its own evidence, decided not to follow directly WHO guidance because it felt it was inappropriate. So having data at scale allows you to do a whole bunch of things. So one is understanding mortality and the risks for mortality. And I think we've conducted the largest multi-hospital study of this with over 90,000 admissions included. And this has also then allowed us to create prognostic scores or prognostic prediction models that allow us to use case mix adjustment for reinterpreting hospital mortality so that we don't essentially, we account for the variation in case mix when we're trying to understand whether hospitals are performing well or performing badly. That was observational research, and I could provide other examples. Now I'm going to jump to interventional research. because of the network we had established when WHO wanted to test in what they called an implementation trial, but wasn't a trial, Kenya was one of the countries they picked for that because the network that we had established allowed them to track severe malaria admissions in the area of Kenya in which they were, which is highly endemic for malaria and therefore where the vaccine would be used. And so we were able to contribute 3 years worth of data on the effects of the vaccine on severe malaria cases, with a particular focus. There was a signal from earlier trials of this vaccine that there might actually be adverse consequences in terms of an increased rate of meningitis, although nobody could explain that. It was a flag from the earlier trials, and so we were both able to track severe malaria cases, but also track other non-severe malaria cases of coma to show that there was no excess, at least in Kenya. So what I'm showing you is how we basically used the learning health system principles. All of this so far I've been talking about is based on exactly the same data platform. So we've improved routine data. It's actually the primary data is collected by the medical officer interns, and we harvest the data, if you like, at discharge. We've used it for improvement. We've used it for observational research. We've used it for understanding the effect, in this case, of a malaria vaccine. And then we've also used exactly the same data platform to conduct individually randomized controlled trials. So layering all of these things on top of one another. So we like to think we've been doing platform trials for quite some time now. But unfortunately, people are not that keen on supporting the learning health system idea in low-income countries, although we believe it can work, and we believe it's actually very cost efficient. So my colleagues, as I say, during COVID, we set up the severe acute respiratory infection surveillance, and you'll all, I'm sure, know of the Discovery trial, which showed that dexamethasone was useful in severe COVID. The challenge was in Africa and in Kenya, we didn't know who had COVID and who didn't. We just knew that there was severe acute respiratory infection. So this pragmatic trial was, well, what happens if you give dexamethasone when you can't make the diagnosis of COVID? And 2,000 adults have been enrolled, and the results are now ready and will be reported soon, which will, I think, be extremely helpful to large parts of Africa which cannot make diagnoses of COVID or influenza or anything else. They just see an adult with severe respiratory illness. A little bit before that, we had started, or colleagues had started, a randomized controlled trial of severe childhood pneumonia, because children, despite there are really extraordinarily few high-quality trials of some of the most common in some of the most common diseases of childhood still. And so this is by far the largest trial that's been done on severe childhood or hospitalized pneumonia. And it was to compare different antibiotic regimes with a factorial design in which we also were trying to test whether these children should be given IV fluids or whether it was still okay to give them nasogastric feeds, which would be potentially more practical and potentially beneficial given the absence of any calories and any useful calories in intravenous fluids. And this trial has also been successfully concluded with recruiting over 4,000 children. And results of that should be out soon too. Not content with individually randomized trials, we're using exactly the same platform, or have used it, to do other forms of pragmatic trial. In this case, we've conducted cluster randomized trials where we've been randomizing the hospitals to different interventions. And so we're just at the end of a cluster randomized controlled trial to see whether we can reduce gentamicin prescription errors. Gentamicin, the aminoglycoside, is the go-to drug with penicillin for neonatal sepsis in our setting. And we have no therapeutic drug monitoring. So people are using standardized doses of gentamicin, or should be, that are appropriate for both age, postnatal age, but also birth weight or gestation, whichever data they've got. And unfortunately, that means that there are several different calculations you may need to do, and medical officer interns, it transpires, are not very good at switching between these different calculations. And so gentamicin dosing errors are reasonably common in this population, and our aim was to reduce them by using technology-enabled feedback. And here we were using quite a lot of feedback intervention theory to help us try and design the best possible feedback intervention. And in another recently completed study, we've been looking at what impact it does if we actually increase nurse staffing. Because in these settings, we have one nurse on neonatal units, and neonatal units have between a 10 and 15% mortality rate. We have one nurse looking after 15 to 20 babies. And actually, there's an awful lot of missed nursing care, which we've documented in other work. And so the critical issue seems to be pairs of hands, nursing pairs of hands, and not technologies in these settings, in our opinion. So that's the sort of more clinical epidemiological side of all this. In parallel, what we've been doing is essentially implementation research since the early 2000s. And we've tried to be reasonably explicit about how we theorize our intervention as a learning health system should work. And so we try and state upfront our hypotheses about how these systems work so that we can then test them. And this is a series of work that's continued for, again, over 10 years, and has resulted in some quite interesting thinking around the power of networks, as amongst other things, to produce change in health systems. So, and this has involved us moving into different territories, hence the interdisciplinary nature of our work. So for implementation science, and here we're using realist methods to unpick what it means to be a network and how they work, which has been actually very instructive in terms of how we would try and replicate these activities that I've talked about. We've used the same platform because we've now can understand many of the clinical problems that exist and the challenges of implementation in real life. We've used other forms of work, qualitative work, to investigate the system and what the challenges are. Recently published work on why it's going to be extremely difficult to introduce routine microbiology in these settings. And so when people talk about AMR, our opinion is that there is almost no data on antimicrobial resistance that's from routine settings in the public sector in African countries. Nearly all of it comes from tertiary centers, and often private tertiary centers. And it's hard to know whether they're at all representative. But it's going to be very difficult to get standard wet lab micro working in these settings. We've looked at how patients move through systems to understand how we need to improve the service delivery components, not just the clinical practice. And we've examined management and what it would mean to be a team leader or a senior health worker in these hospitals. And these are issues that are largely ignored, but actually critical to any change process. And we've explored the effects on both the staff and the patients in these settings. So both nurses who are critical to service delivery, they're the largest profession, as they are in every single health system, but they tend to not feature in global health research. So we've undertaken a body of work on nursing, which we're still doing. And we've also looked at what it's like to be a medical officer intern in these hospitals, where essentially you have an absentee boss, not because they always want to be absentee, it's because there's only one of them and they can't do 24-hour calls 7 days a week, a year. And not surprisingly, it's an extraordinarily stressful experience, which probably damages quite a few of them. We've essentially got data suggests there's quite a considerable amount of PTSD in the medical officer population. And we've also been exploring and developing work on mothers' experiences as one, we need to improve it, but how to improve it and what will it take. So in summary, we're 10 years on. We've got data on about 2/3 inpatient episodes, predominantly more children, quite a lot of newborns, and a reasonable number of adults. We feel we have developed real world insights. We've got ability to track trends over time. We're informing practice, and we're able to do research at scale, and we inform policy. So we feel, and we've engaged our stakeholders, we feel that we've embraced pretty well the learning health system principles I started with. And really that's where we got to, and it's clear that while I'm doing this presentation, it isn't just me that's done all of this work. It's been a huge collective effort, notably from the people in the hospitals. As I mentioned, they don't get anything out of this. There's no remuneration for the people in the hospitals. And so the people that have invested their time and energy have done it because they wanted to see improved care for particularly children and newborns, and more recently adults in these high stress, low resource government hospitals. So we literally have had thousands of contributors to this work. Just to give you some insight, the medical officer interns who are on the wards in which we're collecting data, the whole team changes every 3 months, and we've been able to sustain levels of practice that are sustained despite these rotations every 3 months for the last 10 years. The platform's enabled many people to start their research careers. It's enabled some people to advance their research careers very considerably, and hopefully it's been a good thing for most people, although still lots of work to be done. And I'd just like to thank everybody. And we've been not exclusively funded, but I've personally been funded by Wellcome for most of the last 25 years. And I don't think this would have happened without them and the core support they give to the Kemmery Wellcome Trust. But let me stop there. Thank you.
Thank you very much, Mike. That was just fantastic. I'm going to start off with one question, and then we'll open it up clearly for everybody to be able to jump in here. In this incredible network that you've built, could you comment perhaps on what are the real 1 or 2 health conditions that really stand out where you've been able to move the needle? And I think it would just be interesting to see how that played out for you in the setting.
Thanks, that's a good question. I think within the network, the 2 very common childhood conditions that we've been able to influence are pneumonia management and diarrhea dehydration management. So Kenya's not endemic for malaria across the whole country. So we've also influenced malaria, but it's in a subpopulation of these hospitals. And then within neonatal care, well, actually, I think there's one issue much more generally, which is careful prescribing. Because as I mentioned, these young doctors really had almost zero training before they were launched into the world and responsible. And essentially, with our guidance, we've been able to give them a resource that allows them to get, I mean, we've got very high levels of usage, for example, of first-line antibiotics, much, much higher than you see in AMR literature. So I think those are the some of the key contributions.
Terrific. Let me open it up for questions. Maybe Sam, I could start with you, and then we'll open it up.
Thanks. Thanks, Mike. Again, terrific presentation. I was wondering about the learnings from this 10-year experience. What are some of the salient lessons that can be translated from this low resource experience to a high income settings? You know, are there some commonalities that we can draw upon, or what would you say? We are trying to build this complicated learning health systems here in this country and in other high income settings, but what's your experience from Kenya will help us with?
Yeah, thanks. So A year or two after we started, I had the pleasure of catching up with Chris Forrest, who some of you may know from PedsNet. And so, you know, we obviously they've been able to do things at considerably greater scale and with considerably more resources than us. I think the main lesson is you can do a lot with relatively little. But a lot of the hidden work, and I can say this here, so the Wellcome didn't know they were paying for a lot of this work. So funders do not want to hear that you're spending money on talking to people. They want to hear that you're doing a trial. So we had to use creative ways to make this all happen. But I think my key message is don't feel you can ignore the relationship building that will be required, and trying to make sure that your partners do get, they're nothing monetary, but they get something out of it. They're valued. And I think our efforts to meet people 6 monthly face to face were extremely important.
Thanks. I saw Chris just last week actually talking about PedsNet and how we can be your site as well. Just a reminder to all the audience, you may have to type the question in the Q&A. If you have any questions, you can also type them anonymously if you don't want to be seen. And I think we may have time for just one or two final questions.
Varun, it looks like you're ready to go.
Yeah. So thanks, Dr. Simon. Amazing work, Professor English. Great to hear that across the spectrum of quality improvement, observation research, and interventional trials. One issue which we are facing here, especially and likely in England too, is the prohibitive cost of clinical trials, especially with some of the when you're trying to readdress the use of some generic drugs. So, and you have been, I'm sure you had to innovate and think quite a bit to perform these in resource-limited settings. What is that you think you've learned, which we could use, like similar to what Sam mentioned, in the area of clinical trials, from routinely captured electronic health records, right from identification of patients through just randomization within the electronic health records, and designing an outcome which could purely be captured by electronic health records, and to do a trial at a very low cost, which which would enable many of us, or most of the people, to answer very important clinical questions for which industry funding is going to be very difficult to get.
Yeah, thanks for the question. So the individually randomized clinical trials did require us to put in the equivalent of physician assistant, one per hospital. So because of our data collection process being at discharge, we couldn't use it to identify patients real time. But actually that was, I suspect that would be needed. And even in the recovery trial, there were people working at the coalface, if you like. So our cluster trials are being done without anybody on site working on that particular site. So it's probably, well, my guess is that it may not work that well if you completely expect everything to happen online. But we've never had the opportunity to test that. But I think it's also, one of the things I've railed against is the lack of external validity of many studies, because much evidence for the low middle income world is drawn from the high income world. And you know, how does it translate? And so what we've tried to focus on is effectiveness, not efficacy, and, you know, make sure that our patient inclusion criteria are whatever turns up. But that means doing things bigger. So and that may suit some diseases. When it suits a common disease like pneumonia, you know, inherited rare diseases, this isn't going to suit. So I think if you've got a common event and you can measure the outcome, then it lends itself to a highly pragmatic study, which we found is much more convincing to the clinicians. So I guess it's picking the right tool for the right job.
Thank you. And just to, yeah, that I think there's another.
Okay,
No.
question in the Q&A from Pranshu. Based on your experience from these pragmatic trials, were there any limitations that stood up on the methodology of using LHS-based trials that we could learn from, especially if implementing in a high resource setting?
I think, well, I don't know whether people are familiar with the PRACY 2 guidance. So I think part of it is actually deciding what you mean by a pragmatic trial. So you can be pragmatic in multiple dimensions. I think if you're relying on routine data systems, then you clearly need a pretty unambiguous health outcome. And if you want something much more refined as a health outcome, then I would be more suspicious that the electronic health record is potentially giving you lots of misclassification error or possibly bias, and that would be my concern.
Okay, well, thank you very much for all of you for participating today in our distinguished lecture series. I'm going